Okay, hello. This is Dr. Philip May, and today I'll be talking to you about the osteoclast in health and disease. Before we get started, I just want to briefly review bone resorption and bone formation. And first, starting with bone resorption, since the bone cycle seems to start with bone resorption, shown on the bottom here. For some reason, osteoclasts begin to remove calcium from bone. That's what we're going to be talking about. Why does the osteoclast suddenly start removing calcium from bone? Or maybe not so suddenly, but the point is that something triggers the osteoclast to start taking calcium out of bone, starting to demineralize bone and releasing calcium in the bloodstream. And of course, this will happen if the serum calcium gets too low. As you all know, the serum calcium is tightly regulated, with parathyroid hormone and the feedback system, so that the serum levels of calcium are tightly regulated. And if that serum calcium starts to drop, then the osteoclast can kick in and start to take calcium out of bone to get the calcium levels back up. And they create a little pit in the bone, shown here at the bottom here. Osteoclasts are large multinucleated cells that are actually formed from osteoblasts through the action of a rank ligand, which was the topic of another lecture. But after the osteoclasts are done, and this process takes a couple of weeks, the repair begins. And at the top there, you see the osteoblasts start to produce osteoid, and they fill in the pits that were made, these tiny pits, with new bone after the osteoid becomes mineralized. Okay. So there are two different processes that we need to think about here. And these two processes play a role in determining the quality of bone, the bone strength, the resistance to fracture. And these two processes, either of which can become abnormal, the bone formation rate, BFR, or the bone resorption rate, BRR. Now, normally there is a coupling of these two processes so that the bone formation rate basically equals the bone resorption rate. Now, the net effect is that when bone is resorbed, it is repaired by bone formation. And so that you end up back with normal bone. So if these processes become uncoupled, one becomes out of sync with the other, then you run into bone problems. So that loss of bone strength will occur when either the bone formation rate slows down, and this can happen during the normal aging process, or in a situation where there's very little physical activity, weight-bearing physical activity, to stimulate bone growth. So the other process that you have to consider is the bone resorption rate. And if that speeds up at a proportion to the bone formation rate, then the bone starts to become demineralized. And causes of that are, of course, menopause, or in males, andropause is also a reality. The testosterone levels start to go down, and men actually become estrogen deficient. It doesn't have the same consequences as with women, but the drop of estrogen then causes the osteoclast to become activated, just like it does in women. And also vitamin D and calcium deficiency and chronic kidney disease, CKD, and acute loss of mobility can all lead to activation of the osteoclast and an increase in bone resorption rate. Again, just to review that, to always think in terms of resorption and formation, and if there's too much resorption going on, the bone resorption markers shown here on the right side of resorption, the bone resorption markers begin to increase, and you can see in the serum the rise of collagen telopeptides, and CTX and NTX. One is the C-terminal telopeptide, the other is the N-terminal telopeptide, start to rise, and the N-terminal telopeptide can be measured in urine as well as serum. But these are the two clinically useful telopeptides that give a good indication of increased osteoclastic activity. Looking at the top there on the bone formation markers, the bone alkaline phosphatase, the P1NP or the osteocalcin can go up as an indication of osteoblast activity. P1NP has become the most popular and seems to be the most reliable marker of bone formation. P1NP stands for procollagen type 1 N propeptide, and that is an indicator of osteoblast activity and bone formation. So typically, if one goes up, the other goes up, and usually the collagen telopeptides will increase, and then the P1NP will increase. So you see the CTX go up, and the P1NP will go up along with it. Maybe not exactly the same time, but eventually you'll see a rise of both markers because these processes are coupled. Now, let's take a few minutes and go over this complicated looking slide here, because this kind of reviews the physiology that leads to increased osteoclast activity, which you will see in normal health with bone remodeling, and in disease processes such as post-menopausal osteoporosis and osteomalacia. But starting over on the left-hand side, you see in the red rectangle says decrease of serum calcium. And that's what starts the process going. Now, what causes a decrease of serum calcium? And this may not be a huge drop, with dangerously low calcium. The calcium fluctuates within the normal range from a higher normal to a lower normal. When it starts to get a little bit too low for the body, then parathyroid hormone secretion increases. But the causes of this, on the top there, it says severe dietary deficiency of calcium, can certainly lead to a drop in serum calcium. And then in the below circles there can be a decrease of active vitamin D from low sun exposure, drug toxicity, or renal failure. And when you have a low level of active vitamin D, and that's the 125 dihydroxyvitamin D, this can lead to decreased intestinal absorption and or renal reabsorption of calcium, and that can lead to a serum calcium drop. But if the serum calcium goes down to a certain point, the parathyroid hormone secretion will increase and the PTH levels will rise. And once that occurs, the parathyroid hormone will stimulate the formation of rank ligand on the osteoblast. And rank ligand stands for receptor activator of nuclear factor kappa B. And this will, what rank ligand does is it interacts with the rank receptor on macrophages, circulating macrophages, and converts them to osteoclast. So parathyroid hormone stimulates the osteoblast to make osteoclast. So interesting that the osteoblast makes bone matrix, but it also stimulates osteoclast formation at the same time. So once you get osteoclast formation and activation, shown in the yellow box there, this can lead to demineralization of bone and an increase of serum C terminal telopeptide of type 1 collagen, or CTX, which then corrects the problem by increasing serum calcium. As the bones becomes demineralized from the tiny pit there, calcium is released into the bloodstream and can feed back, if you follow the big arrow there, to PTH to suppress the PTH, so it shuts the process down. Now, there are other ways that osteoclasts can become activated. And at the top there it says physical inactivity and loss of mechanical stress on bone, which is detected by the osteocytes, can activate osteoclasts. And if physical inactivity is acute, suddenly someone becomes paralyzed, the osteoclasts become acutely activated, and you can actually get hypercalcemia, from that. So this is different from just not being in physical condition and not taking your daily walks and stimulating bone growth with weight-bearing exercise. Now, also with menopause and andropause, shown at the bottom there can be a decrease of serum estrogen, and once the estrogen levels drop, this will lead to activation of osteoclasts as well. So this is the feedback loop to prevent hypocalcemia. The life-threatening thing here is if the calcium gets too low, this can cause very serious problems, arrhythmias and malfunction of every conducting tissue. So calcium, you have to keep the calcium levels normal, and this is one way that this happens. Now, you can see that if you become dependent on osteoclast removal of calcium from bone, then eventually the bones are going to get very weak and become prone to fracture. So you want to make sure that you have plenty of dietary calcium and vitamin D to promote the calcium absorption, so you keep those levels up, and you don't need to activate osteoclasts to get the calcium out of bone, because you're getting it in your diet and you're absorbing it thanks to the action of active vitamin D. So you can kind of put the bones to rest and just take calcium from bone only when necessary. So this still, you need this process for remodeling to remove old bone and put new bone in. And about 10% of the skeleton is undergoing a remodeling process at all times. About 90% is not. But you need that to renew bone and to keep it young and healthy. It's a little different process from maintaining the calcium homeostasis. So there are two different processes that you have to consider. Okay, so in conclusion, it is important that the physician determine the level of osteoclastic activity as a measure of bone resorption rate in their patients who have low bone mineral density by DEXA analysis. If osteoclastic activity is increased, the evidence for that would be the CTX or NTX would be elevated. If that's the case, then that person needs to be worked up. The cause of that elevation of bone turnover should be determined and treated appropriately. Of course, vitamin D deficiency is probably a common cause of that in people with complex disabilities. But of course, menopause is going to be a problem as well. If vitamin D deficiency is one of the causes, and you determine that the person is vitamin D deficient, then you should treat the vitamin D deficiency first before any bone pharmaceuticals are started. Unfortunately, a lot of times DEXAs are obtained and the bone mineral density is shown to be low, and a person is put on a bisphosphonate, or perhaps most commonly a bisphosphonate, and the vitamin D level is not really checked even. And if it is checked, the levels of 25-hydroxy vitamin D are not really optimized before the bone pharmaceuticals are started, and this can lead to some major problems with the regulation of calcium. So by all means, correct the vitamin D deficiency before you start the bone pharmaceutical. So the most important thing to consider: people with chronic disabilities are likely to have multiple etiologies for low bone mineral density by DEXA. So if you get a T-score of -3 or 2.5, something like this, or 1.5 osteopenia, there may be a combination of aging, kind of osteoporosis kind of stuff going on, or there could be some osteomalacia from vitamin D deficiency. And it's important to remember that the DEXA machine cannot distinguish the low bone mineral density caused by post-menopausal osteoporosis from the low bone mineral density which is caused by osteomalacia from vitamin D deficiency. So it's very important to remember that, and so check the vitamin D level and replace or replenish vitamin D before you start the bone pharmaceutical, because you may find that just correcting the vitamin D with calcium will improve the bone mineral density to such a degree that you don't really need a bone pharmaceutical. So it's very important to do that. Okay, thanks for listening. Stay tuned for other talks on this topic of bone health and people with chronic disabilities. Bye-bye.